Thank you everybody for coming, particularly because there is a lecture by Nobel laureate happening at the Medical Campus. So we appreciate you coming. It's my pleasure and privilege to introduce Jerry Menikoff, who will be speaking to us about challenge studies. So in front of me, I have a long page of the achievements of Jerry, including his time leading one of the main regulatory bodies in the US for medical practice, for medical research. But instead, I chose to show you this picture, showing you who Jerry really is. And this is from a trip we just completed in Harbin, China, together with some of the people in this room, actually, as students and lecturers. And I can tell you, we had wonderful time with Jerry, and students learn from him through experiences and through chats over lunch, breakfast, dinner, long walks under the rain, under the sun, and what have you, under various conditions. And we deeply, deeply appreciate, and I'm sure the students deeply, deeply appreciate, but this is not our topic for today. So please help me welcome Jerry.
And particularly thank you to be here. It's great to see everybody, given the competition. And I particularly want to thank the students from the trip for coming to this. I want this to be very informal. I think I'll kind of wander around in front here as I give the talk. Feel free to interrupt at any point if you have questions or comments or whatever. Again, very informal. Okay, so let's see. Okay, so here's the talk. So I'm talking about challenge trials. My goal in terms of this talk is to both introduce you to the ethics of challenge trials, but as a way of doing that, I want you to understand how we think about research ethics. So that's sort of a joint goal. And I think if you understand research ethics correctly, challenge trials actually make a lot of sense. So we're going to talk about challenge trials. And let me start by talking about what a challenge trial is. Okay. So a challenge trial is a research study, what we call a clinical trial, that involves intentionally exposing participants to some sort of infectious agent. It could be a virus, it could be bacteria, other types of more obscure infectious things. And there's actually a long history of doing this. And so part of what I want you to understand is the difference between what researchers have actually been doing for a long time and what came up during COVID. And again, by understanding that difference, we actually can think about what we might want to do in the future. So talking about that long history, if you go back, Edward Jenner, he exposed children to smallpox in the 1790s. There were obviously ethical issues about how he did that because he didn't get appropriate consent. But of course, this was hundreds of years ago. So you can't really blame them for not understanding where ethics should, is today versus what it was hundreds of years ago. One thing about what Jenner was doing was that he was exposing them in a way that actually sort of was interventional with them, that was actually, producing some sort of immunity. That's not the classic sort of challenge trial I'm mainly going to be talking about today. Most of the challenge trials that have raised a lot of issues recently are when whatever you're doing in terms of the challenge is infecting somebody with something, but they're not actually benefiting from being infected. Whereas with Jenner, he was actually looking for the effect on the person. So just be aware of that in terms of the background. So you had Jenner, 1790s. More recently, Walter Reed. He exposed people to yellow fever around 1901. And then the third item here is talking about more recent very more recent challenge trials. For a long time, there are lots of challenge trials out there. Cholera, malaria, influenza, the common cold. Many people, thousands of people have participated in these challenge trials and been exposed to very serious diseases. You know, when you see this list, this was my reaction to it before I knew what was happening in terms of challenge trials that are regularly taking place. It was like, these are really serious diseases. Actually, millions of people are still dying from these diseases. So again, my guess is the natural reaction for many people is, this sounds like a really, really bad thing. How can we ethically be exposing people to diseases that are regularly killing people, even in our current times? And yet, what I'm going to try to highlight, so I just sort of tell you where I'm going with this, is these types of trials are actually not all that controversial, whereas there's a different type of challenge trial that is very controversial. And again, by explaining to you how people in research ethics think about research ethics issues, you'll have this nice understanding, hopefully, about the differences between types of challenge trials and why these sorts of challenge trials are at least ethical, or at least many people think they're ethical. So that's sort of the big picture of where we're trying to go. So why do we do challenge trials? And a number of specific examples I'll go through, or points on this slide, but as an overview, when you think about clinical trials, we often have one particular thing that we're testing. So you might want to test a particular new, drug to treat cancer. And when you do sort of the gold standard for a clinical trial is you often randomize people. You'll flip a coin, you'll assign them to one, like standard care, and then the other half of the time, you'll assign them to whatever drug you're testing. So again, this is the gold standard for doing that. What you want to get a really good result, to best see the impact of whatever it is you're testing, for example, the new drug, you want the two groups to be as similar as possible, except for the thing you're testing. That's why you're randomizing. And so, in effect, a general way of describing what you're trying to do there is you're trying to eliminate all the other variables. You're trying to get rid of the noise. And I think a way to think about challenge trials is that you actually, again, want to get rid of all the other noise that would occur in some other way of doing this type of testing. And the challenge trials let you do that. So going through the bullets on this slide, they can let you produce much faster results than more typical clinical trials, particularly when you're testing vaccines. So for example, let's assume you were in the early days of COVID and when we first developed a vaccine and you wanted to test that vaccine, you could give it to a whole bunch of people who were out there living in different places, doing different things, some of them staying home, some of them going to work, just doing very, very many different things. In many ways, all of that is noise. It actually makes it harder to figure out what the vaccine is doing. For each of those people, you don't know when they might actually be exposed to COVID. You don't know how much that exposure might be. All of this, again, is messy, and it makes it harder for the researchers to actually know what they're learning and what they want to learn in terms of how all the vaccine works. So by doing an actual trial, and in particular a challenge trial, this allows the researcher to minutely control the exposure of these people to the infectious agent. You could be certain that the patient, the participant in the trial was exposed to a certain very specific amount of the COVID, and when they were exposed to it and how long the exposure was. Again, all of that can be controlled in the trial, whereas virtually none of that is controllable if, again, you're just giving this vaccine to people and they're going home and wandering around. You don't know if they had already been exposed to COVID before you actually gave them the vaccine. Again, this is all noise. You just don't know, the effect of the noise. Whereas the challenge trial lets you control all of this, and by controlling it, you could get much, much better science in terms of the results. And as noted, you need to actually to learn as much as you can with a challenge trial. Without doing the challenge trial, you didn't need to enroll many more subjects over a larger period of time. Again, you wouldn't know the actual exposure, things like that. So there are a lot of good reasons, it depends on what specific question you want to answer, but there are a lot of good reasons why doing a challenge trial could be hugely important, particularly when, again, you're dealing with a hugely problematic new type of infection that could be killing thousands, tens of thousands, hundreds of thousands, even millions of people. That's where you're sort of particularly getting a lot of pressure about, well, gee, let's think about a challenge trial. So in the early days, so let me just ask you one question. I'll get audience participation here. Remember, I was noting that we're doing challenge trials all the time. Thousands of people have been enrolling in challenge trials, and often the trials involve fairly deadly diseases like malaria, cholera, dengue fever, influenza. Anybody have a sense of why would somebody enroll in these trials? This is our audience participation. Why would any of you want to enroll in one of these trials? What haven't I told you? Yeah, I heard somebody say something. Yeah, money. Okay, money. Excellent answer. It often is money. Something I don't mention in the slides, but it is relevant. You will often get a fair amount of money to be in these trials. Not uncommon an amount. Now, being in a trial will involve a bit of your time. So many of these trials involve maybe 2.5 weeks worth of time, 2 weeks, 1 week, something like that. You're in a facility somewhere, so you can't leave, that building, that unit. So people want something for their time and effort, and you could end up getting, in terms of a lot of these trials are conducted in the United Kingdom. Often you could get like £5,000. You guys are better than me in converting it to Hong Kong dollars. That would be, I assume, a fair amount of Hong Kong dollars. We could separately talk about the ethics of whether it is okay to do that. I will give you the answer from, I think, the dominant viewpoint in research ethics these days, which actually we shouldn't worry so much about paying people to enroll in clinical trials. It's actually a good thing. These people who are enrolling are helping all of us by helping us learn answers to important research questions. What people are sometimes concerned about in terms of paying people is that it's, well, some people will describe it as coercive. Probably not coercive. Coercive is when somebody puts a gun to your head and threatens to do some bad thing if you don't do what they want. So nobody is, in that sense, coercing people to be in these trials. What they are doing is providing a very strong inducement. If you're relatively poor, your family doesn't have good health care, you could get £5,000 from being in a trial. You might feel a strong incentive to be in a trial, which some people might describe as undue influence, undue inducement. But the issue would be, as long as you're a person who can make their own decisions about their life, all of us make decisions all the time about whether or not we want to take a particular job, which may be risky. Maybe you want to join the police or be a firefighter, and those are risky jobs, and we let those people get large amounts of money to expose themselves to risk. So maybe it isn't so bad that we're doing these challenge trials and paying an appropriate amount of money to people to participate in them. And again, happy to talk more about the paying people issues here. Okay, so let's say a little bit about how this is related to COVID-19. In the very early days of the COVID-19 pandemic, so we're talking about 2020, there was a lot of discussion about using challenge trials to develop the vaccines. In fact, to develop the vaccines earlier than it otherwise would have taken. And at the time, I think the general thinking was in terms of the sorts of trials they were going to do, and we'll talk a little more about what the specifics are. This was somewhat viewed as controversial when prominent people were saying, let's do a challenge trial on COVID, and we'll get into why it might be viewed as controversial. The trials did eventually start. By this time, there have been 4 or 5 that have been conducted, but they didn't start immediately. None of them started in 2020. The earliest started about March of 2021. That's when the first subjects started getting enrolled. And by that time, we knew a lot more about COVID-19. And so that might explain why we eventually went forward with at least one challenge trial by that time. It works out that the challenge trials that were conducted only played a relatively minor role in fighting COVID-19. They played a pretty minimal role in actually developing the vaccines. And these are fascinating issues, and they're particularly fascinating in terms of the future, because there are still unanswered questions about what's going to happen the next time we have the next pandemic, and whether or not we want to actually use challenge trials then, and whether the challenge trials then might have more an impact than the challenge trials did in COVID-19. So we'll talk about that and what happened with COVID-19 that might be done differently the next time around. So let's get into why there was controversy, or why challenge trials in general might be viewed as controversial. So I'm going to turn to giving you my take. And I think this is the take of a fair number of people in the field about how we should think about research ethics in general, and then we'll apply it to challenge trials. So here's a proposition. Society does everything possible to protect the interests of people who are participating in clinical trials. And that sounds pretty reasonable. I suspect many of you may think this is a good thing. I know I've heard from people, like in terms of Hong Kong, and I'm sure mainland China, a lot of people are somewhat nervous about being in clinical trials. They might even be nervous about dealing with clinicians and whether they're getting the right amount of clinical care. And this is probably similar around the world. Many people are a little nervous about clinical trials. So obviously, if we want to get them into the clinical trials, we want to reassure them that everything possible is being done to protect their interests. And again, from my viewpoint, this is an incorrect statement. You really shouldn't be able to say this. If you're saying this, you're not understanding what happens in clinical trials. So let's think about what really does happen in clinical trials. And to explain that, let's back up and talk about clinical medicine. Let's talk about the relationship, the rights and duties between doctors and patients. Doctors have a special duty in ethics and law to their patients. And it's a duty to almost always do what's in the best interest of the patient. Above all, do no harm. The shorthand that I often use is the patient is number one. That's the basics of medical ethics. If you as a doctor don't fulfill that obligation, you're usually committing malpractice. And this obligation was known for thousands of years. It goes back to Hippocrates and the Hippocratic Oath. Above all, do no harm, what, primum non nocere, or however you pronounce the Latin. And in particular, a patient cannot waive this duty. This is a paternalistic rule that our society has been put in place to protect patients. And it's an important rule. It's a core rule of the relationship between doctors and patients. So that's our starting point, the doctor-patient relationship. Now let's tweak that, and now let's turn to thinking about the world of research in distinction from the world of clinical care. So when you're conducting research, why are you doing it? The core conclusion there is you're doing it to answer a research question. And when you're doing that, what you do can involve doing things that would not be in the best interest of the participants, of the subjects in the study. And here I have some examples. These are the most common examples. There are other examples you could kind of come up with. So for example, randomizing people to different treatments. In the real world, outside of clinical trials, or other ways of testing things, we often don't do randomization. So if I asked you the last time, or not just the last time, anytime you went to a doctor, did your doctor ever tell you, well, as part of your clinical care, there are these two drugs that are both used by a lot of other of my colleagues to treat your medical problem. What do you say? I'll flip a coin and we'll give you whichever drug that, heads or tails. I don't think your doctor's ever done that to you. I've asked a lot of doctors this question and I've never gotten that as an answer. In ordinary life, we generally don't randomize. If you're trying to figure out what movie you want to go to this weekend, you're going to look at the movies out there and you're going to try to find some information about them, and you'll probably make your best guess about which movie you're likely to enjoy. You're going to use the information you already know to make a best choice. That's probably what your doctor is going to do in terms of talking with you and making a shared decision about any aspect of your medical care, right? They're not going to want to ignore information that is already out there. And that's why they don't flip a coin. Yet in clinical trials, we often randomize. That's the gold standard. So again, not being done for your best interest, it's being done to get good results. You don't individualize treatments in clinical trials. Often, if you have pain, your doctor will figure out the right dose of the medication that best reduces your pain with no side effects. In a clinical trial, if it involves painkillers, they will often have a standardized dose that any of the participants in the trial will get. The reason they're doing that, we sort of talked about that. This would create extra noise if you're kind of fine-tuning each person's, pain medication level. Again, the goal is to do what's best for getting the answer. That's what the clinical trial is about, answering a research question. You'll often get tests that may be harmful. You could get a lumbar puncture. They'll stick a needle in your spine, which can be, fairly uncomfortable. And the results of the test will not affect your clinical care. It's being used by the researchers to best figure out, what you want to learn in the research study. There could be a failure to disclose information, such as interim results. Again, bottom line, these are standard ways that clinical trials are conducted, and many things are happening that are not in the best interests of the participants. So comparing this to clinical care, if the doctor was doing these things to a patient in the clinical care setting, it would be malpractice. It would violate the patient is number one rule. But we want to enable research to be conducted. It's important to society. New medical knowledge benefits all of us. So we created a special set of rules to allow research to take place. And what they do is they actually weaken the rules relating to clinical practice, which would normally require the doctor to almost always just do what's best for the patient. So notice this key final bullet here is sort of almost the opposite of what that proposition I started with, that, well, in clinical trials, hopefully we're doing everything to advance the best interests of the patients. No, we're not. We created special rules that allow weaker protection of the interests of the patients. And this sounds like it's a bad thing, but no, it's not a bad thing. We want research to take place, but we want it to take place under appropriately ethical circumstances. So basically, bottom line, the rules for research allow us to take account of the conflict of interest between trying to pursue two separate goals: conducting the research, answering the research question, and doing what's best for the participants. We want to allow things to be done to the participants and that are not in the best interest, but we want to put limits on that. We don't want horrible things to happen to them. And we have a set of research rules that do that. And so I'm going to talk about one aspect of those rules. This is just describing some of the principles behind the rules, and in particular from the US side, there was a thing called the Belmont Report back in 1979, created three principles that are in one version or another used around the world: respect for persons, autonomy, which is people should control what happens to them. So this is about getting informed consent, beneficence, and the flip of that, non-maleficence. Researchers should try to do things that will help people, that will produce benefits. And it could be benefiting the people in the trial, or it could be benefits to society by learning things. And of course, you want to minimize harms. And the third thing is justice. And that's an issue of making sure different groups of people only suffer their fair share of the harms and get their right percentage of the benefits. So these are the general principles. The difficult thing is balancing these trading among these principles. So now, most of what I'm going to talk about now are about risks, because those are the big ticket items in these sorts of trials. How much risks are we exposing people to? In the US regulations, they're applied through these committees around the world. They're sometimes called research ethics committees in the US and even in Singapore, where I'm now. They're called institutional review boards, or IRBs for short. And one of these committees reviews every proposed research study and determines whether it complies with the appropriate rules. And I want to talk about one particular rule that I'm going to concentrate on. And this is the big ticket rule about risks in these trials, what risks are allowed. And the rule here is that the risks to the subjects have to be reasonable in relationship to the sum of two other things: the benefits to the subjects and the importance of the knowledge that may reasonably be expected to result. So let me rewrite that in hopefully a more understandable form. You could think of it as an equation, and it's basically saying the risks to the subjects sort of have to be outweighed, or approximately outweighed, by the sum of two things: the benefits to the subjects and the benefits to society. Now note there isn't any upper limit on the risks to the subjects. And notice, due to the benefits to society, right, on from your viewpoint, the right side, the benefits to society extra thing that is added in means that, right, the risks to subjects can actually be outweighed, can outweigh the benefits to the subjects. And perhaps they can greatly outweigh the benefits to the subjects. So I'm going to drill down on this equation and explain how we could use that to think about different types of challenge trials. It happens that the benefits to society in clinical trials are often going to be, all of these numbers actually are going to be hard to put actual numbers on. And the benefits to society are especially hard to quantify, because often when we're doing a clinical trial, we don't know what the outcome is going to be. And we don't know how important what we're ever going to learn is going to be. So I just want to suggest to you there are two common behaviors that these IRBs, these review committees, often employ when they review and approve research. First of all, they'll emphasize very good informed consent. Ultimately, it's the people who are going to be good enough to enroll in these trials and expose themselves to risks, often for the benefit of the rest of us. They're doing a wonderful thing. Let's at least make sure they know what they're getting into, what risks they're exposing themselves to. And secondly, if we're not sure how much benefit will come from any clinical trial, well, by putting something close to a zero value on the benefits to society, we're being a little conservative. We're being more protective of the interests of participants in these trials. So these are sort of behaviors that these IRBs often exhibit. And I want to show how we could then apply this to these challenge trials, okay? So what does our equation become if we assume the benefits to society is close to zero? It's basically that the benefits to the subjects should be approximately equivalent to the risk to the subjects, or perhaps outweigh it vaguely. You know, again, that's why I have that little wiggly line there. Approximately, you still could have the risks, you know, being a little greater than the benefits to the subjects. And if a study has no benefits to the subjects, then we're basically saying the risks to the subjects shouldn't be huge. They should be, you know, really small. close to zero. So if you have a study that has no benefits to subjects, and remember that most of the challenge trials I want us to think about today will not be doing much in terms of benefiting to the subjects, right? They'll be exposing somebody to some horrible disease so the researchers can learn about it. So if you're applying all the assumptions I'm talking about here, you're not going to want these trials to be incredibly risky. And this is, again, a general way IRBs operate. They're reluctant to approve studies that have no benefits to subjects if they're very substantial risks. So now let's apply that concept. We're going to apply this to the challenge trials. As I told you, researchers actually have been exposing subjects in clinical trials to really, really bad diseases that kill people: malaria, cholera, the flu, dengue fever. And let me call those, I just want to give a description, lower risk challenge trials. And I'll explain why I'm using that description. They've been doing this for years. Now, when I say they're not particularly controversial, it's not particularly controversial in the world of people who do these trials and the people who approve them and the ethicists who are familiar with them. And I want you to understand why, in fact, that is an appropriate conclusion. These trials were designed so that the subjects would be exposed to a very low likelihood of dying or long-term morbidity. In other words, some permanent health problem that they have for the rest of their lives. And I admit, in the parenthetical here, there will be in these trials, not infrequently, some degree of short-term discomfort. These people may be very uncomfortable and very sick for a week or two. But under the rules I told you about, it's perfectly okay for these research ethics committees, even the conservative ones, to approve these trials because it meets the standard that I just talked to you about. That in terms of risks, the risks aren't horrible. Yes, the people may be sick for a week or two, but no long-term horrible things happening. And we actually have a group of researchers who did a review of virtually every major challenge trial that's been done up to now. They found more than 15,000 participants, and among those 15,000 people, more than 15,000, they found only 24 serious adverse events. And when they're talking about serious adverse events, that's not talking about deaths, and it's even not talking about any permanent health damage. So basically, 24 things that don't even involve death or permanent health damage is the only bad thing that happened among more than 15,000 people. And these are trials involving malaria and cholera and other things that, again, people were intentionally exposed to those diseases to see whether they would then develop them, even though they were, for example, given a test vaccine. So this is actually proving that these trials actually meet that minimal risk standard that I was telling you about. We've been doing all these things and people aren't suffering all these horrible harms. And so the question is, how were they able to do this? I mean, these are diseases that in the present are still killing millions of people: malaria, cholera, the flu. How are the risks made so low? People have gotten smart. Researchers are very good at creating rules that make sure these trials are very, very low risk. How do they do that? They intricately control the amount of exposure, right? Because this is all done under controlled conditions. The type of exposure, they control the infectious agent you're being exposed to. So there are types of malaria that are actually hard to treat, but there are types that are easy to treat, that they know we have drugs that will treat them. They use a version of malaria that they've studied and they actually grow it. And again, it's all done under controlled conditions. They control who they admit to these trials. Healthy people, young people, certainly people who do not have other medical problems. So the bottom line is we've actually turned this into a well-understood science about how you do these sorts of trials. And you know that they're minimal risk. So this is where sort of the bottom line here is. And am I still talking about that? Right. Okay. And so here's an example of doing that even with COVID-19. Currently, there is a trial occurring. It's out of Imperial College, out of London, on coronavirus, on COVID-19. It's enrolling 120 subjects. Here's what it's trying to learn. how much of the Delta virus, that's one of the versions of COVID, is needed to cause infection, even if you've been vaccinated, how long vaccinated people remain infectious after a breakthrough infection, what happens in infected people with no symptoms. So just showing you there are questions we still have to answer about COVID. And we now have one of the, I told you, 4 or 5 COVID-19 trials. And it's occurring now. And I just want you to understand it is meeting the standards I just told you about how to use these trials and make them minimal risk. And this is just from the consent form, which is, by the way, online. So if you just Google Imperial College consent form COVID-19, you could find this. And I think it's a really wonderful consent form. They try to get people to understand. They tell you, look at Wembley Stadium, right, somewhere in the UK. I've never been there, in Wembley Stadium. It holds 90,000 people. And if you enroll in this COVID-19 trial, the risk of death would be that between 0 and at most 1 person out of that 90,000 people would die. And they then point out, actually, the risk in the trial is 10 times lower than that because they're actually getting vaccinated people in the trial. You can't be in the trial unless you've been vaccinated. Then they tell you the risk of ICU admission and hospitalization and give you numbers about it. And these numbers are low enough that they meet our standards of saying, gee, that's pretty low, right? You multiply to 90,000 by 10 since they're vaccinated, 1 person out of 900,000, that's a pretty low chance, right? If you drive 100 miles on a trip on a highway, your risk probably of dying from, a car accident or something is probably, in that range, I'm guessing. So that's why these sorts of trials are pretty minimal risk. Okay, and this is just pointing out, Singapore is about to be starting a COVID-19 trial. I think it's the 3rd country in the world that is doing current COVID-19 challenge trials. And it would be very similar, probably. It hasn't fully disclosed all the details, but the take is that it's going to be pretty similar to the Imperial College trial I just told you about, the ones that we're currently conducting. Now I want to switch and close by moving to a different issue about riskier trials. Remember, we go back to our equation. If a study has no direct benefits to the subjects, risks to subjects are kind of in the ballparks of benefits to society. And remember, we were assuming that was 0. The conservative IRBs. What if there were circumstances in which the benefits to society from conducting a certain type of trial could be huge, that you could actually save tens of thousands, hundreds of thousands, maybe even millions of lives by doing this one trial? If that was true, under our current ethical rules, that you really thought this benefits society term was really, really big, and you were pretty sure about that, you could actually have the risk to subjects be very, very large too, because it would still meet our standard of being justifiable. The benefits would so huge, yes, it would actually justify really serious risk to subjects. And that really serious risk to subjects could include a non-trivial chance of death or permanent morbidity, permanent damage, health harm. Under those circumstances, such studies, which I will call higher risk challenge trials, could both be ethical and legal. Not clear whether any such studies have ever been conducted. And I'll give you an example. I was writing about this almost 20 years ago. This was after 9/11, and people in the US were genuinely paranoid after seeing what happened on 9/11, and that other countries were going to attack us in other ways, not sending planes to crash into buildings, but bomb us with anthrax and other infectious agents, use chemical and biological warfare. And so what if there was some new biological warfare threat that we were trying to adopt, some sort of, remedy for, and to test whether it really worked? You test it in animals, that sort of thing. Maybe you'd actually want to, expose some consenting subjects. We're talking about people who know what they're getting into to this toxic agent, even if we knew that many of them might die in the testing. That still might be ethical, and that's the proposition. During the early days of COVID, This is what I was talking about when I started the talk. There were very few treatments. A high percentage of infected people were dying. It was those higher risk challenge trials that people were talking about, because at that point, we didn't know enough about COVID to design them in the way that our malaria and cholera and other trials are designed to be minimal risk. And the interesting thing was there was surprising support from leading bioethicists, including Peter Singer, Princeton, and Arthur Kaplan. These are very famous bioethicists who you could debate how conservative they are, but it was interesting that they were supporting this. I supported something similar. I wrote about this in mid 2020. And this is just quoting, some of what Singer said about this. And he's basically just noting here, that a lot of people were volunteering at the time. There was a website One Day Sooner, and it had thousands of people, particularly young people, who were saying, we want to help. If we could actually save thousands, tens of thousands, hundreds of thousands of lives by volunteering, exposing ourselves to substantial risks, we're okay with that. Again, this is the higher risk, challenge trials we're talking about here. By March 2020, bioethicists were writing about these trials, and we're noting, obviously, challenging volunteers with this live virus at that point would have risked inducing severe disease and possibly even death. And they know we'll try to reduce the risks, recruit healthy younger patients, those in high transmission rates areas. But even with that, we don't know that you're going to meet this. You probably wouldn't meet the standards for declaring these to be the lower risk challenge trials. They're just a different type of trial. The WHO created a working group still in 2020, producing key criteria for ethical acceptability of these challenge trials. And you could go through them, they all make a lot of sense. But note, they never say that it has to be minimal risk. They're acknowledging we may be exposing people to substantial risks, including possibly substantial risks of death or permanent health damage. That was what was on the table at that point. And this is just another quote from them. I'll just finish that up because we could discuss this, including severe disease or death can occur in young adults. Again, these higher risk challenge trials. And so here I'm just giving you a site for one of the early, I think this was the earliest COVID-19 challenge trial that took place. It enrolled people beginning in March of 2021 through July of 2021, enrolled 36 subjects. We did have a treatment, remdesivir, available by that point, and they discovered they didn't have to give it to people because the risks were so low. So even the very first trial that took place, I think many of us would say, met the standards of being a low-risk trial precisely because it occurred over a year after we knew about, what COVID was about, and we had already studied it. And no serious adverse events actually were reported in this trial where 36 subjects were enrolled. So it's unclear that we've ever did, even with COVID, any of these higher risk trials. And so sort of I laid it out, we still have this open issue. The next time we encounter this kind of new infectious agent or whatever, we may have on the table the question, can we learn a great deal more quickly by doing a challenge trial? And it will depend on what the infectious agent is, how much we know about it, how long it's going to take us to design, the vaccines, that sort of thing. I think that's still a very open question, but the big ticket item is these higher risk challenge trials and when we should conduct them. And just remember, these are very, very different than the standard low risk challenge trials that we've been conducting for years and years. I think that's the end of my talk and we have time to discuss. Thank you. Oh, this is just a book I wrote about 15 or so years ago that discusses the view I gave you about what research ethics is. So